Typically, the training for sleep medicine is approximately 7 years. Even the best bed partner is going to have a hard time telling. All the muscles in the upper airway start to relax, and then the airway opens and closes very quickly. I always wanted to help relieve suffering. I think there's health problems are a major source of suffering and pain. Yeah. So it's a very rare disease. They have monitors placed on them at night to measure their snoring, the breathing, and the oxygen levels, and the sleep. And then we can determine with high precision how bad the sleep apnea is.
Hola a todos y sean bienvenidos a un episodio más del podcast Mente Médica, auspiciado por la consultoría Medicina académica. En este episodio estoy muy emocionado porque voy a entrevistar al Dr. Luu Pham, médico del Hospital Johns Hopkins con un entrenamiento de más de 9 años en Neumología, Cuidados intensivos y también Medicina del sueño. Además también es investigador con un enfoque en afecciones de la respiración durante el sueño. El día de hoy como especialista nos va a comentar por qué ocurren los ronquidos, que en algunos casos puede relacionarse a la conocida como apnea del sueño. También nos comentará acerca de esa afección en la cual una persona se duerme repentinamente, conocida como narcolepsia. Y finalmente compartirá con nosotros algunas recomendaciones para personas que estamos haciendo investigación. Así que empecemos con este episodio. Thank you very much, doctor, for accept this interview.
Thank you very much for having me.
The first thing that I would like to ask you is about what motivates you to, or what did motivate you to practice medicine?
I always wanted to help relieve suffering. I think there's health problems are a major source of suffering and pain. And so that had made me, my main interest has been to relieve some of that suffering and improve quality of life.
Great. And for sleep medicine, which training did you make?
So I did several different steps. So first I trained in general internal medicine. Then I did a specialty in pulmonary and critical medicine, pulmonary and critical care medicine. During that training, I was with my first sleep study, and I saw all the types of exposures that occur during the night, low oxygen levels, heart rate racing, pauses in breathing. And I thought, wow, this is a potential major source of health problems for patients. And so I then underwent an additional training in sleep medicine.
Yes, medicine. Excellent. Did you tell me that your training was 9 years to get the spine, right?
Yes. So I did typically the training for sleep medicine is approximately 7 years. So you do 4 years of, well, it can be 7 years depending on the tracks, the background. So for me, it was 3 years internal medicine, 3 years of pulmonary and critical care medicine, and then 1 year of clinical sleep medicine plus an extra 2 years of research training.
Okay, excellent. 9 years, a long time to...
Yes, 9 years is a long time.
So I really would like to ask you, to the knowledge of all the people that see this channel, what causes the sleep apnea and what is so common now in our society?
So there are two types of sleep apnea. One is called obstructive sleep apnea. That's where the airway starts to collapse during sleep. And when the airway collapses, the oxygen levels drop low, and then they have to wake up to breathe again. And so this happens repeatedly throughout the night. So the main risk factor for sleep apnea is actually weight gain, obesity. And as obesity becomes more common because of trends in health in the United States and other industrialized countries, so too is sleep apnea become more common. The other type of sleep apnea is called central sleep apnea, where patients don't try to breathe periodically during the night. And that's usually related to a couple of different things. One is heart disease. It has to do with delay of control of breathing, and the other is high altitude can cause central sleep apnea.
Excellent. And so we have these two main causes. And what is related, for example, with people that may snore, the nose?
Yeah, so snoring is just airway collapse. So when you fall asleep, all the muscles in your upper airway start to collapse, and then the airway opens and closes very quickly, and that causes the snoring sound. If you still get enough breathing, enough ventilation, then you can maintain your oxygen levels and maintain your breathing, and you just keep sleeping, and that becomes continuous snoring. If the snoring becomes to such a degree that you can't breathe enough, well, at some point you wake up and take a couple extra breaths. Okay, so that's when it becomes sleep apnea. And then if the airway collapse is so severe that you can't move any air at all, then that's an apnea. And then what happens is oftentimes the bed partner, the wife or the husband, says, "Hey, my spouse stops breathing at nighttime," and so it's a range of severity of the airway collapse.
Okay, excellent. And this sleep apnea have some impact in the health, right?
Yes, and so based on several large epidemiological studies, we know that sleep apnea is a risk factor for early mortality, particularly in men, heart attacks, strokes, high blood pressure, diabetes. So a lot of chronic health problems.
Okay. And how we can recognize when the snoring is harmful for health?
So yeah, this is actually very difficult to differentiate continuous snoring from sleep apnea. If the common things or symptoms are awakenings at night, so patients with sleep apnea often wake themselves up with gas, or may even wake themselves up snoring. If the snoring is so loud that it bothers others, the bed partner can be heard in the bedroom next door, that's usually a sign that that there is likely sleep apnea. And finally, daytime symptoms. If they are sleepy during the daytime, regardless of how much sleep they've gotten, there's a chance that there's something disrupting their sleep that causes them to be sleepy. And so there's a good chance that they're symptomatic from their sleep apnea.
Okay, excellent. Do exist any kind of test that someone can do to diagnose?
Right. So, these signs and symptoms that I just mentioned, they're not very specific. It's hard to differentiate between continuous snoring and, apnea. Even the best bed partner is going to have a hard time telling. And so a sleep study is the main way of determining how bad the apnea is, how likely the patient is to have a complication from the sleep apnea, and whether or not they need some type of treatment. And so there are a couple of different sleep studies. There are several home studies that measure oxygen levels and your breathing patterns at nighttime. So they can do it at home and send this result, and the doctor can give them the results. And for more complicated patients, we often actually study them in the lab, meaning they come to a specialized laboratory. They have monitors placed on them at nighttime to measure their snoring, the breathing, and the oxygen levels, and the sleep. And then we can determine with high precision what how bad the sleep apnea is.
Yeah. Okay. Excellent, doctor. And in case a person has already sleep apnea, what are the recommendations?
So the main risk factor is weight loss. And in some patients, particularly men, if they lose enough weight, the sleep apnea can be cured. So we always recommend weight loss. There are certain things that make sleep apnea worse. Alcohol markedly worsens sleep apnea. So it can turn someone who just a fort into somebody with bad sleep apnea. So alcohol, we ask patients to minimize alcohol intake. And then, if the apnea is to a level that we think causes health problems, then we also recommend other treatments, including what we call CPAP, or constant positive airway pressure therapy. is basically a little fan that sits on the nightstand, connected to a mask that goes over the nose and applies a little bit of pressure to the upper airway to open the airway up and allow them to breathe. If patients can't tolerate the CPAP, then there are other things that can be done. There are what we call oral appliances that move the jaw forward to help keep the airway open. There are certain surgeries that help some patients. And there's a newer therapy called hypoglossal nerve stimulation, which is an implanted device that goes in the shoulder with a wire that goes to the hypoglossal nerve, a nerve that innervates the tongue and stimulates the tongue, kind of move it out of the way during sleep. But those are less effective and have higher risk. So we try weight loss and CPAP first, but the vast majority of patients.
Weight loss and CPAP.
Yes.
Excellent, doctor. And I want to also ask you about the narcolepsy.
Yeah.
This is maybe a strange disease, no?
Yes. Yeah. So it's a very rare disease.
Yeah.
I think the incidence is less than 1 in 100,000. So it's pretty rare. It is a disorder where patients fall asleep very easily particularly during daytime, and may interfere with the ability to do work. And that's after ruling out other potential causes of sleepiness, like insomnia, like circadian rhythm disorder, meaning that they're just not sleeping at the right time. It has to do with a hormone called orexin. And so patients with narcolepsy can't stay asleep or stay awake very well, and so they flip-flop back and forth between wake and sleep. The main therapy for narcolepsy is try to make sure they get enough sleep, because they're very sensitive to sleep deprivation. Right, so making sure they get enough opportunity to sleep and taking naps when possible to decrease the sleepiness. And if they're still sleepy, then we add on a drug to help keep them awake. Stimulant similar to Ritalin or modafinil. Right? So the drugs to help keep them awake. The test for it is actually a sleep study in the lab to make sure they don't have sleep apnea or some other explanation for the sleepiness. Okay. And then finally, we do a daytime nap test. So put them in a dark room, turn the lights out, and see how likely they are to fall asleep and to enter what we call REM sleep, the dream sleep. Normal people do not have REM sleep during the daytime. People with narcolepsy tend to fall asleep very, very quickly. So on average, less than 4 minutes when we give them the chance, and then they enter REM sleep. So we see that they fall asleep very quickly and enter REM sleep at least 2 out of 5 naps during this test. Then we say they have narcolepsy.
Okay, very interesting, doctor. Thank you very much to share that. I also would like to ask you very briefly about the research that you are doing now.
So we're doing research here in Bruno on sleep apnea and the role of hypoxia or low oxygen levels on sleep apnea and its complications. So when you fall asleep, your breathing slows down. So whatever level of hypoxia you have gets much worse during sleep. In Bruno, where you're already hypoxic because of the low oxygen levels, the vast majority of people develop sleep apnea. We did a study close to 10 years ago now, where we saw that approximately 75% of Bruno residents have sleep apnea, and approximately a quarter have severe sleep apnea, which warrants some type of treatment. And so it's very common. It's very severe here. And people in Bruno, because of this environment, develop sleep apnea at a much lower body weight than they would at sea level. And so this becomes a very good environment to study the effects of hypoxia in the development of complications from sleep apnea. what we found so far is the patients who have sleep apnea and low oxygen levels at nighttime have two main outcomes. There are two main groups of sleep apnea here. There are those who fall asleep and kind of stay asleep at very low oxygen levels throughout the night. There are those who fall asleep but wake up periodically to breathe. And depending on which of these types you have, your complications are a little bit different. Those who wake up and breathe periodically have very similar complications as those at sea level. We found that the frequency of those awakenings was linked to a hemoglobin A1C or blood sugar levels. And those who fell asleep and stayed asleep, the level of their oxygen levels at nighttime, the lowest oxygen levels was at nighttime, the more likely they were to have what's called excessive erythrocytosis, a marker of chronic mountain sickness or lung phase.
Okay. It's a very complex
Yeah.
interaction of things. Excellent, doctor. I really also would like to ask you if you have any advice to improve sleep
In general, or
in general.
in general, I think a couple things. Routine helps. So staying on a regular schedule helps improve your ability to sleep. Avoidance of light exposure at nighttime.
Yeah.
Avoidance of alcohol. Alcohol makes you sleepy, but also wakes you up during the latter half of the night and makes sleep apnea worse. And finally, if you have signs and symptoms of sleep apnea, then get a sleep test.
That's the sleep test. Excellent, doctor. Just a final question. An advice also for example, our researchers that maybe are still studying in this way. Yeah.
So I got into high altitude sleep medicine as it wasn't planned. It was an opportunity. So I think a lot of research is seeing what opportunities are available, making the best of them. And when you take advantage of those opportunities, then a lot of a whole world opens up to you. So just be flexible, look for opportunities and see where they take you.
Excellent. Thank you very much, Dr. Luu, for this interview.
Thank you so much. Thanks for having me.
Thank you
It's
so
been a
much.
pleasure.
Muchas gracias a todos por haber visto este video. Agradezco bastante al Dr. Luu por haber estado con nosotros. Y les recordamos que en este podcast de Medicina Académica seguiremos hablando mucho más acerca de medicina, investigación y otros temas. Así que nos vemos en una próxima oportunidad. Hasta luego.